Hi everyone, welcome to the Surgery Service RN Mandatory Education. Please make sure your sound is on. There is a survey link that has to be completed in order to be compliant, so make sure you fill in all the necessary information. And thank you for your patience and understanding during this time. I know everyone is stressed out, but we will get through this. So thank you for your attention to this important matter. We're going to cover three things in this PowerPoint. First being suicide, the documentation for that, the rating scale and orders, and then medication, so non-PRNs, PRN administration, and how to document those properly. And then at the very end is titration, like using RAS with your titratable drugs, and pause and sedation, and some other information with that. So if you are not in an ICU and you're not titrating drips, you do not have to pay attention to the very end of the presentation. So you will see whenever that comes up. Okay, so this is a very high priority. All inpatient nurses must complete the Columbia Suicide Severity Rating Scale, also known as the CSSRS tool, within 1 hour of the patient's arrival. So if they come from the ED, it should be done, but you definitely want to check to make sure. If it was completed, you have to do the rescreener, which we'll talk about pulling that in. And then if it's a direct admission, you're going to do the initial CSSRS scale. It's the full risk assessment, and we'll talk about that. And then if it's a transfer, you're going to check to make sure the initial scale was done, and it's usually in the admission navigator. And if it was completed, you need to do the rescreener. So at a minimum, you're going to be doing the rescreener for a patient, but just depending on where they've been and if it's been done, you either do the full assessment, which is the initial screening, or a rescreening. Okay, just like every other policy that we have on the intranet, you're going to go to Policy Stat under UNC Medical Center. And you're going to, in the toolbar, search bar, whatever it's called, you are going to look for suicide. The policy will actually be dated August 2019. So hot off the press. And so you'll see August 2019, suicide and self-harming behavior under Policy Stat. Everything you ever needed to know is in the policy. But we're going to go through most of it here. So this is just a breakdown here to kind of show you the different levels of risk. So again, within the first hour of admission, the patient should be screened. If they are no risk, so there's these levels: no risk, low risk, moderate risk, or high risk. So if there's no risk, they're not going to have to ever have anything else done. Okay, so no risk only. If they're low risk or moderate risk or high risk, you're going to initiate the suicide care plan for that patient. And then if they're low risk, they will have a rescreen every day. Okay, so daily. And then the moderate risk, if they flag moderate, which we'll look at that, how they flag, a PNA or a telesitter has to be ordered. You have to notify the provider. The provider is going to use another scale. They're going to initiate their own care plan, and they have a scale that will help them determine whether the patient is low or high. If the patient is high risk, there are suicide precautions ordered. So it's one-on-one supervision. The environmental survey is done. There has been separate education provided for the nursing assistants regarding the environmental survey and their 15-minute safety checks. So again, that's been done in a separate PowerPoint. You're going to place a sign on the door. Those signs are available. You can order them. They're, again, you're going to have the care plan initiated. They're going to be rescreened daily. So if they're low, moderate, or high, you're essentially going to be rescreened daily. But you're going to continue this process. The provider has to discontinue suicide precautions if that's needed. During your rescreening, they may go up or down on the risk scale. So again, that's what's in this orange box, or whatever color that's called, skin colored, at the bottom here. If patient's behavior and or clinical prognosis changes, it indicates a change in risk level. You're going to rescreen them. If you're unable to assess the patient on admission, you're going to document in the medical record and complete the initial screen. You must initiate a care plan for low, moderate, and high-risk patients. So on inpatient units, this is the admission navigator. It's, again, if you look at this screen, this is a screenshot to show you the Columbia Suicide Screening, the severity rating scale, and you're going to start with question 1. Just a key point, if the patient's unable to answer, so that they're intubated, sedated, they have dementia, whatever the case, then leave the assessment blank, because if you fill out any of it with comments, it will no longer let you know, hey, this is not complete. It will see it as completed, and then, you will not be compliant because it's not complete. So, you want it to continue to alert you, because hopefully your patient's going to recover and ideally be able to answer these questions at some point. So after completing the CSSRS, you're going to document any risk factors for suicide that the patient may verbalize. So you can see the red box on the left. You're going to check any of these if they're applicable. Again, if they're admitted through the ED, they are completing the screening, but the initial screening, but it's still good to check. So all patients are screened using questions 1, 2, and 6, so they're numbered. If questions 1 or 2 are answered yes, then questions 3, 4, and 5 kind of populate in or cascade in. The system determines the suicide risk when all questions are answered. If questions are all answered no, then the risk of suicide field is left blank. So if the patient answers no to questions 1, 2, and 6, they are deemed no risk. And if there's nothing else, then there's nothing else you need to do if they're no risk. So just making sure that you go through. If questions 1 and 2 are no, that you skip straight to question 6. Just so you know, this is really important. The question is not currently, it goes straight to question 6. This question is not currently showing up as a required question to complete the admission assessment, meaning that it could show that the admission is complete, even if question number 6 has not been answered. So then you would not truly know your patient's risk. So just making sure you answer all of them. Okay, so once this scale is complete, a BPA, which is a best practice advisory, I know you all know that, automatically triggers, and if it's a patient at high risk. And so if this is dismissed, like if you just keep hitting dismiss, it will keep reappearing until you place the order for the patient to be on suicide precautions. Okay, so don't keep dismissing it. Like, order what you need, and we're going to talk about that. Okay, so to place the order per the hospital policy, which is dated August 2019, in Policy Stat, you're going to the priority will be stat. The suicide precautions now have comments with additional instructions. You just use the appropriate order mode and follow the policy if you're looking for word. But it's suicide precautions. It'll tell you environmental safety survey completed every shift, 1-to-1 patient, one-on-one patient care, so PNA, with Q15-minute documentation. You need to put a sign on the door. Elopement precautions also, if it's a baby, the hugs stuff or pediatric electronic stuff. So please, follow all that's in the order. Just so you know, there is also food nutrition therapy also needs to be alerted, and it does not automatically alert them. So the suicide precaution order does not automatically do that. So you'll want to make sure in the nutrition therapy part of the admission assessment that you click suicide precaution so that the patient gets the appropriate tray and utensils. Okay, and again, you are required to initiate the suicide care plan. There's several charts, and we're all auditing like crazy. So there's several charts that have not initiated the suicide care plan, but the patient is on suicide precautions. So a banner displays in the overview reports for all clinicians when a patient is on suicide precautions and the order is active. It looks like this. And then when the order is discontinued, the banner goes away. All right, so required documentation report shows the suicide screening for admission and the shift. Suicide initial screen is done at admission. Rescreening shows on the required documentation report only if the patient initially screens as low, moderate, or high. If the initial screen shows a blank risk field, rescreening is not going to show on the required document report, which is why all the questions have to be answered. Finally, the required documentation shows rescreening only for patients 12 years or older, and it's completed daily based on the time of the last assessment. So if you look in the bottom right side of the screen, it shows you the time that it's required. So again, if they're transferred to the unit by the emergency department and the initial screening was complete, it will be the admission required documentation will be satisfied. So just again, making sure that you're checking that required documentation to make sure if you need to have the rescreening complete, you look at the time there and know if it's needed or not. It's daily though. Okay, so if you look on the if you want to see what was last documented, like when was the last time the SSRS was done, you can check the last filed and it will show you when it was done last, which is good information. So ongoing, like daily, what do I need to know and how is this going to affect me? So there is the initial screening. It no longer says short version, but there's an initial screening and then a rescreening. So you can pull those in, so wrench them in to your flow sheet. So you'll see at the top it says CSSRS at the tab, and you're going to complete that documentation. So it will tell you the row information helps answer the questions. So especially, of course, when you're doing the rescreening, you're not going to memorize those questions, or at least I couldn't. So that's required documentation there. So per policy, completion of the checklist should be documented in Epic. So we all have those paper checklists, and everybody's always like, I don't know what to do with them. I don't know where to put them. Just save them in the patient's room or something. But no, you, as the RN, you need to make sure that you are selecting suicide, documenting in Epic by selecting suicide precautions under safety intervention. So, we're doing our daily cares and safety rounds, and so under safety interventions, you can write a comment there of environment checked for safety or environmental checklist complete. And so you can see that screenshot there, but you also want to make sure you're selecting suicide precautions under safety interventions. Okay, so that was fun to talk about suicide, right? So now we're going to move on to medication management. This is what we need to work on. So your help is needed to ensure that UNC is compliant with Joint Commission. We all are aware of that. So Standards on safe medication administration. So the hospital has a written policy that defines what actions to take when medication orders are incomplete, illegible, or unclear. So we're going to look at assessment and reassessment and documentation of pain and non-pain PRN, therapeutic duplication, linked orders, titration, pausing sedation. So this is a lot. Again, the stuff at the end is mostly critical care units. So if you're having to pause for neuro exams, etc. And then we're going to talk about the correct documentation. Pain and non-pain PRN medication administration. Under PRN pain, you assess and document the pain using the appropriate pain scale that's appropriate for your patient. So if your patient is talking and walking, then you shouldn't be using a nonverbal pain scale. So making sure it's appropriate, and you're going to administer the correct medication and dose for whatever the reported level of pain is. So your orders, which we'll talk about, but we'll say for mild pain 1 to 3, moderate pain, I don't know what your physician or provider will put, but you have to make sure that your pain scale is matching the order of the medication that you're giving. So if more than one medication is ordered for the same indication, the order needs to clearly indicate which medication to administer over the others. So you can't document 2 medications given at the same time. So for example, Tylenol and oxycodone, unless the order actually says give in combination with Tylenol under the oxycodone, or under the Tylenol give with oxycodone, there has to be an order that says that. Otherwise, you're given 2 pain medications at the same time, and you only have 1 pain score. Hopefully that makes sense. So making sure your order says that. And then you have to reassess and document your pain within 60 minutes of pain medication administration. So making sure you do the pain reassessment within 60 minutes. Does not have to be exactly, meaning like 11:01, 12:01. If it's 11:01 and 12 o'clock, it's within 60 minutes. Okay? So non-pain PRNs, this is what gets a lot of folks. You're going to document a pre-assessment on the MAR in the comment section. So if I'm giving Zofran for nausea, then I'm going to document a pre-assessment in the comment section. Documentation includes the PRN reason, so nausea, vomiting. Reassessment includes the response, like no nausea and vomiting, or sleeping, or whatever the response was. The post-assessment must be completed with appropriate time frame for the administered medication. So again, you're following up on non-pain PRNs as well. Sorry, that was a long slide. Okay, so you're in administering PRN pain meds per pain scale. Again, this is just a screenshot and an example. The orders have to be written on the patient's pain level. You have to review the order. It is permissible for a patient to be given a pain medication indicated for a lower score than what they report, like a less potent PRN med, upon the patient's request. There must be documentation to reflect the reason for the deviation. It's not permissible to administer a requested medication indicated for a higher score. So in this screenshot example, if the patient reported a pain score of 10 but requested the Tylenol instead of the Dilaudid, that would be okay as long as your documentation reflects that it was patient's preference. When you go to on your medication administration record on the MAR, at the bottom of the PRN or the pain medication, you can click on CMAR medication, and it will automatically populate this into your pain assessment, which helps to remind you to do the reassessment and to the comprehensive pain assessment, something that a lot of people are leaving off. So if I document a pain scale score of 6, then there needs to be, where is it? What is it? How's it working out? Like what's going on, instead of just a pain score of 6. Okay, when administering pain med, this is what I just said, sorry. Click medication CMAR under pain assessment. This will link the administration to the pain assessment in the flow sheet and a column will automatically be entered into the pain intervention row at the exact time that you gave the medication, which makes it easy to fill out the pre-assessment pain score and other relevant assessment findings. So PRN pain medication pre- and post-assessment documentation. Pain must be assessed and documented prior to the medication administration. Your intervention has to be documented, and then a post-assessment must be documented. For non-pain PRN medications, document the PRN reason on the MAR in the comment section when you're administering it. So PRN medication due to wheezing or whatever the indication is. So if it's Zofran, nausea. So you're going to put that in the comment section. Then the post-assessment, so under response to PRN medications, non-pain, it's in the assessment tab. This section often must be added as a new row by the RN. So you have to click on flow sheet and open the assessment, and then click add rows at the top. There is a screenshot here. Type in PRN in the pop-up box, and then accept. So it will put that row in there for you, so you can document the PRN post-assessment. So the PRN response assessment. And it must be within the expected parameter of onset of action per policy. So orders are required for PRN meds. Patients can only receive PRN meds for the reasons that they are ordered. It is not acceptable to administer PRN meds if the patient does not meet the parameters. A patient has an order for Tylenol, 650 by mouth every 6 hours, PRN for pain, 1 to 3, or a fever, 38.0. So here's the order. The patient should only receive the ordered acetaminophen if the parameters are met. So you need to document pain of 1 to 3 or a documented temperature of 38 or higher. If the patient needs a medication for a reason outside of what's here, you have to get a new order. So if the patient says, I have a headache of, I swear it feels like it's a 5, then, and I want to take Tylenol because that's what works for my pain of 5 for a headache, you would have to get a new order. Okay, so therapeutic duplication. It's a problematic situation that occurs when more than one medication is ordered for the same indication without any guidance on which medication to administer over another. If more than one medication is ordered for the same indication, then the order needs to clearly indicate which med to administer over the other. So here's some compliant examples. In the green, so green means go, so woohoo, let's go. 2 meds for the same indication with directions for which medication to administer. So Dilaudid 0.5 milligrams every 3 hours for severe pain, starting at this date and this time for 2 weeks. Okay, and then Tylenol, this dose every 4 hours for pain 1 to 3, pain 4 to 6, or a fever. Oh, and they have a headache in there. It's exciting. So starting at this date and this time. The non-compliant example, 2 medications for the same indication but no directions for which medication to administer over the other. So Zofran 4 milligrams every 6 hours is needed for nausea and vomiting starting this date and time. Phenergan IV every 6 hours, nausea and vomiting starting this date and this time. So 2 medications, same reason you would be given them. They treat the same thing, but no direction or guidance as to which one to give over the other. So that would be a non-compliant example. Okay, linked orders. The cumulative dose administered cannot exceed the maximum ordered dose within the ordered frequency. So, for example, a patient with an order of oxycodone 5 to 10 milligrams PA every 4 hours for moderate pain may only receive a total of 10 in the 4 hours with the current order. If the patient continues to report unrelieved pain, the nurse will contact the prescriber for further orders. I mean, it keeps up with that. So the linked orders, is the dose. Usually this has to do with the dose range. Excuse me. So if you are a acute care nurse, floor nurse, and you're on the floors, you're not in the ICU, and you're not having to titrate drips, you are finished. So just make sure you complete the survey. But if you're a critical care nurse and you're in the ICU or you're dealing with infusions and titrations, please stay tuned. You're almost done. Okay? So we have some areas of improvement with continuous titrations. We really want to make sure we're providing safe, high-quality care. Remember, everything we do is to keep the patient safe, and it may be multiple steps, and it may sound like a lot, but this education and these guidelines are put into place to keep our patients safe. So we want to follow administration on these drips and titrations exactly as it's ordered. So you're going to have to obtain an order for sedation vacations and neuro exams or checks, and you want to document the RASS per policy. This is very important. With every titration, every 2 hours on vented patients. So if the patient is on a ventilator, every 2 hours, and every 4 hours on non-vented patients. So if you have patients who go on the ventilator at night, which happens sometimes in our unit. So during the day, if the patient's not on the ventilator, their RASS can be done every 4 hours. But if they are on the ventilator at night, it needs to be done every 2 hours. And you want to make sure you obtain an order to discontinue any titrations. So sedation and assessment. The provider is going to enter the correct titration orders and manually enter administration instructions because they must be individualized for each patient. And yes, providers are getting education. I know that question has popped into your mind as you've listened to this. So you want to make sure you nurses communicate with the providers when the orders are not correct or they're inaccurate or they need to be adjusted per the patient or the patient's condition changes and you no longer need that high of a range, and so you're going to now get an order to match what is needed for the patient. So you're going to document all titration changes and appropriate parameters. For example, if the propofol is titrated, then the corresponding RASS needs to be documented as well. So, of course, Richmond Agitation Sedation Scale, which is RASS, assesses the sedation, and you're going to document every 2 hours, the RASS score every 2 hours while the patient's on mechanical ventilation. And if you're titrating, the sedation level must be assessed and documented with each titration. So titrate to the ordered target RASS. So your providers, when they put the order in, will say propofol, whatever the range is, for a RASS of -1. Whatever the order says, you have to go by the order. But every time a change is made, so if you go down on your titration or up, then you have to have a RASS score that reflects why. So you can't document an increase in your drip. So like I'm going up on the propofol, but my RASS score every 2 hours has remained -3. And I've not changed it any. I've not documented it in a new one. But in the documentation in the flow sheet, you can see that my propofol has gone up. Yeah, not good, not compliant. So here's an overview. You're going to make sure that the order for the titrated titrated infusion contains the following: the range with a max dose, so 0, it always should start at 0 and go to a max dose, how much your initiation amount should be, how much you can titrate it by, your parameters, and your time frame. If there's multiple infusions for the same reason, the order has to say which one you can titrate first. So if you are coming down from drips or up on drips or whatever, you have to have instructions as to which ones you can titrate first. So the RN titrates the infusion as it's ordered. The RN documents the RASS that corresponds to and justifies the reason for the titration. So if you're going up on propofol, but your your blood pressure is lower and your RASS is -3, that's not correct. Yep. Always provide the care your patient needs first, and orders can be changed once the patient stabilizes or when more help has arrived. You want to collaborate with your providers. So when patient meets parameters at a dosage of 0 and it's determined that the patient no longer needs the medication, then the provider will discontinue the medication in the medical record. Here's a compliant example, and as you can see, there's lots of rate dose changes. So 6 mics, 8 mics. This is norepi. The order at the top, let me start at the top. Sorry, I just went all over. The order starts at 0, which is great, and goes to 30 mics, and it starts at a date and a time. It has your initiation dose of 4 mics, and it says what you can titrate it by. So it gave you those parameters, and it gave you a time limit every 10 minutes as needed, and your MAP goal. So those are all the parts of the order that you need. And it tells you it's initiated order, a titrated order, and your MAP, and telling you to document every 10 minutes. So if you'll look, it shows at 4, it was at 6. So the initial rate was 4, and then 4 mics, and then 10 minutes later, they went up to 6, and then 10 minutes later, they went up to 8, and then 10 minutes later, they stayed at 8, and 10 minutes later, they went to 10, and so forth. And if you look in the vital signs, the MAP corresponds to that. So everything matches up and makes perfect sense. You want a great clinical picture. So for a non-compliant example, you can see that the order is, you've got an initiation rate, you've got a titration rate, and you've got your MAP and everything there in the order. However, the order was not followed because it doesn't match, the documentation does not match the order. So the initiation happened at 8:58, 4 mics, and at 10:17 it went down, and then it went down again, and there was a rate change by just 1 mic instead of 2 mics, which is what the order says. So you can see there that it does not match up. It's non-compliant. So for SBTs or SATs, you're gonna I think that's what y'all call SATs, spontaneous SBTs. Anyway, if you're having to pause the sedation, or the provider will use ventilation and sedation management order set in Epic, and it can be customized. They will select the parameters for the SBT, and SAT, and then the RN RT to perform it will then restart the sedation per the orders, and document that SBT or SAT in Epic. And the order should clearly state out weaning and a sedation holiday. That's why there's a comment section. It needs to be written in there. Again, providers are receiving education as well. Pausing sedation, for neuro exams, they'll write a neurochecks order. The order will state yes or no to pause the sedation. It will state what to pause. It will state when to pause it, and then it will state how to resume it, and the RN will document the neuro exam in Epic. If you'll look on the left side, effective immediately, the provider must address each of these when ordering neuro assessment. So there's a new button for Q1 hour, and then is the patient on sedation? If the provider answers no, either of these questions, then no additional questions will display. But both of these questions are required. Again, they are also receiving education. Okay, this is just some resources. Thank you all for your time and attention, and your patience and kindness and candy and goodies during this time. Just please make sure you complete the survey link, and that it's documented that you completed this education. Thank you.